Okay, we'll go ahead and get started. I know some people joined a little bit later, so if you want to go ahead and put your name in the program that you're with in the chat box so that we know who's in the space, that would be great. My name is Leah Poole, and I am NC CASA's Rural Sexual Assault Services Specialist. I use pronouns she, hers. And today, we're obviously going to be talking about medical advocacy and writing MOUs. Before we get started, I'm just going to go over some general NC CASA information. Okay. So NC CASA is the North Carolina Coalition Against Sexual Assault, and we are an inclusive statewide alliance working to end sexual violence through education, advocacy, and legislation. NC CASA, as a statewide coalition, uses a social justice framework, and our work is done from a strong intersectional social justice lens. Centering our work around marginalized communities, everyone is served. These are some of the different things that we offer. So we have our Training Institute, which is what this webinar is through, our anti-human trafficking outreach, support rape crisis centers, prevention education, resource sharing and technical assistance. We support colleges and universities. We offer language services through our language line, and also we advocate for legislative and policy change. A note about language. Although most reported sexual assault survivors are women who are assaulted by men, survivors who are not cisgender women or whose assailants are not men are often marginalized from anti-sexual violence advocacy. And to demonstrate our efforts to center survivors who may be on the margins of this work, we use gender-neutral language to talk about survivors and harm doers. So things to remember are that any person can be a victim and any person can inflict harm. All right. So some of the goals of this webinar come from personal experience as someone who used to be at a local program, and from feedback I've heard from all of you all at our rape crisis centers about how valuable a good MOU with your local hospital can be in reducing harm and further traumatization for survivors. MOUs that we will be talking about today will be specifically related to hospital and medical advocacy, and largely around survivors who choose to have a forensic medical exam completed. So some of the overarching topics and what I hope that y'all are able to get out of the webinar today is being able to feel better equipped to write MOUs with your hospitals, feeling prepared to work with hospitals and rape crisis centers when patients are being sent out of your county, gaining knowledge and building partnerships and MOUs with law enforcement specific to sexual violence, gaining knowledge in maintaining MOUs, and feeling equipped to write culturally competent MOUs. So briefly, I'm also going to talk about language in this context. Throughout the presentation, I'll primarily use forensic medical exam. I prefer this term because not everyone who chooses to get an exam following an assault experienced rape, and not all survivors want to call the assault that occurred rape. Other terms that are often used are evidence collection kit, rape kit. And as always, match the language and the tone of the survivor. So if the person that you're working with wants to call it a rape kit, then by all means, match that language. And adding medical to forensic medical exam, places the emphasis on the importance of this exam not just being about collecting evidence, but also making sure that other healthcare needs are met. I really hope today can be like pretty interactive and that y'all can be engaged. So if you do have MOUs, and they don't even necessarily have to be with your hospital, but if you just have good experience writing MOUs, I would love to hear about that experience. So you can type that in the chat box and share with the group. We're going to get started with a poll, and that should pop up on the screen. Okay, so our first poll, it's anonymous, so we're going to do 4 polls today, and they're all anonymous. The first one is, do you already have an MOU with your hospital?
Right, I'll give the poll another 20 seconds. It looks like we have a few more people that still need the vote. All right, so it looks like 23% of you said yes, 31% said no, 15% says we have one, but it's outdated, and 31% said I don't know.
Okay, great. Thank you all so much for sharing that. And I think, hopefully after today, it's just like a good opportunity to think about, do we need to go back and revisit MOUs? If you don't know if you have one, this is like a great opportunity for you to talk to your agency about whether or not that's the case, if you do. The Wikipedia, so MOU stands for Memorandum of Understanding. And the Wikipedia definition of an MOU is a type of agreement between 2 or more parties. It expresses a convergence of will between the parties, indicating an intended common line of action. I felt like this was just like a really succinct definition. But I think I would add, in the context of the work that we do in our relationship with hospitals, that an MOU is an agreement that holds all parties accountable for providing the best patient care. It's important to note that an MOU is not usually a legally binding contract. So, if someone doesn't necessarily adhere to the MOU, there most likely isn't any like legal grounds, unless of course they do something illegal. But it's still just really helpful to have, again, for that accountability. And typically they're put in place by the Rape Crisis Center and the other party to ensure patient care, like I said. So what are some of the benefits of an MOU? If you are someone who answered that you do have an MOU or just a good relationship with your hospital, would you mind sharing some examples of how having this relationship has been helpful? And I'll give folks a couple minutes to type in the chat. Okay, I'm going to repeat the question, and then I do see some folks are typing. So the question was, if you're someone who does have an MOU with your hospital, how has having the MOU benefited you and the survivors that you're working with? How has it been helpful? Someone responded that it creates guidelines for both parties to adhere to and a cohesion that benefits the survivor. And I think that that's absolutely true. And that's, part of why having an MOU is so important and why we're talking about it, so that everyone can kind of be on the same page. So it's less confusing, especially in a crisis situation and in the hospital. And there's so many things that are going on, and there's so much information being thrown at the survivor patient. it can get really overwhelming. So if everyone's kind of on the same page, that's really helpful. Okay. If anyone has anything that they think of or that they want to add, feel free to put it in the chat. We're monitoring that. So some of the benefits that I have written here are it can help facilitate relationship building for the Rape Crisis Center and the hospital. So we know community partnerships that are developed and maintained can lead to better outcomes for the survivors we work with and reduce stress for everyone. The first step after this webinar may not be to go straight to your hospital and say, hey, we need an MOU. A good first step may be just to open the door for relationship building and getting to know the people who you may ask to help write the MOU later. And I think it's really important to talk about what each other's actual and perceived roles and responsibilities are. Because, you know, sometimes we know what our role is as advocates, but the hospital doesn't necessarily know what kind of training we get. So being able to kind of communicate that can be really helpful, you know, what our role is and what we're here for. If you already have an MOU, your next step may be to review the current one and figure out what's still relevant and what might need to be updated. You know, it's really important to find out, like, hey, are the people who originally wrote this MOU still employed by both organizations? Because if not, you know, obviously that means that you're probably due for an update. Another benefit is that it can hold each other accountable for survivor care. So that's kind of what the person who responded in the chat box was getting at. I know I've heard from a lot of rape crisis centers about horror stories at the hospital, and an MOU isn't going to solve all of those problems, but it is a good tool to reference when something does go wrong. And we'll talk about this again when we get to what goes in an MOU. I also found when doing direct service work that hospital emergency departments have a lot of turnover, and we recognize that that happens at our rape crisis centers as well. So having an MOU can help with the onboarding process to know kind of what to expect when working with the partner. It can also provide a doorway to educate your hospitals and healthcare providers about trauma-informed care, specifically for those who've experienced sexual violence and about survivors' rights. As part of the series, we did a webinar on survivors' rights. So if you want to view that, you can do that through Coalition Manager or on NC CASA's YouTube page. So the next section that we're going to get to is pretty much the bulk of the webinar. So before we move on, does anyone have any questions or examples or anything like that? And if so, just feel free to put that in the chat. Okay, someone said that they think they're so new to this, it's hard to have any questions yet. And that's a really like valid answer. So thank you for sharing that with us. I think that a lot of people might feel that way. So I'm happy to just kind of talk and see where it goes. So, so we're going to talk about what could go in an MOU. So I would say this is specific to the hospital. So when you're working with your hospital, it's really important to kind of talk about what are the hospital procedures. So when a patient shows up at the hospital and says that they're there because they experienced a sexual assault and they want to get a forensic medical exam done, what's the hospital protocol? So an example might be that the patient should not have to wait in the general waiting room. If at all possible, they should have a private waiting room until the exam room is ready. And later on in the webinar, I'm going to show a sample MOU that I created that's like really general, really vague. But there will be like more detailed examples in that as well. And I will share that with you all after the webinar as well. So another thing that could go in an MOU, what should go in an MOU is the RCC procedures. So what is the Rape Crisis Center and the advocate's role? What is the duty of that advocate when they respond to the hospital or get a call? There should also be information about anonymous reporting, because there will be some patients who seek forensic medical exams that do not wish to have an advocate present. It may be helpful to include in your MOU with your hospital under their procedures that they'll be at least a little bit knowledgeable about the patient's reporting options so that the patient can make the right choice for them. So in the event that the hospital doesn't call your Rape Crisis Center, or the patient says that they don't want an advocate present, the hospital having a little bit of information about what the survivor's options are is just really helpful in making sure that the patient can make informed decisions about kind of what they want to do. I know I've heard stories from advocates that their hospital will call law enforcement immediately upon a patient requesting a forensic exam. This ideally should not be happening unless the patient is a minor. And this piece about reporting options can also help guide your hospital when it comes to whether or not law enforcement should be notified and when. So does this happen in your community? Because there are sometimes extenuating circumstances such as SART teams. I know that sometimes there's agreements between the hospital and the law enforcement agency. Sometimes SART teams decide that law enforcement is going to be called. So if anyone wants to share, their experience with that, please put that in the chat if there's reasons why in your community your hospital does call law enforcement. And I can type that question in the chat because it might have been kind of confusing. And while folks are answering this, I think what's important to acknowledge is that sometimes this is happening and the Rape Crisis Center, the hospital, and law enforcement, they're all on the same page and they know why this is happening. And then I've heard in other situations that this is happening and the Rape Crisis Center doesn't know why, and the survivor is unsure why law enforcement's getting called because they don't want to report. So if it's a situation in your community where this is happening and you're not really sure why, it's probably time for a dialogue between all three of these entities, law enforcement, the hospital, and the Rape Crisis Center, to sit down and just kind of talk about like why this is happening, what are the benefits of this, what is the potential harm in this, and things like that. Okay, I'm going to keep going, but if anyone has anything, just put it in the chat. So another thing that should go in your MOU with your hospital is information about confidentiality. Hospitals have confidentiality rules just like we do at our rape crisis centers. And of course, we all know that they're very different. We know about HIPAA and those kinds of things. So Having language in your MOU about patient consent can just be helpful in making sure that both parties are understanding of the professional limitations when it comes to giving out personal identifying information. And it also helps maintain patient autonomy over who has their information and how and when their information is shared. You may also want to include information around the patient having the right to refuse any part of the kit. I know in the Survivors' Rights webinar, I heard from advocates that they've had nurses who say, if you don't do all of the kit, then I'm not going to finish. And you know, that really shouldn't be happening. The survivor does have the right to refuse any part of the kit that they don't want to do. So putting that in the MOU can just be helpful, because if the examiner is giving pushback, you can reference the MOU and say, hey, like, this was agreed upon when we created this MOU that the survivor has this right. So also billing information. We know that survivors being billed for their kits is a problem, and we want to do as much as we can to prevent this from happening. So just outlining in your MOU that the forensic exam should not be billed to the patient or the patient's insurance. It should be billed to RVAP, or Rape Victim Assistance Program. So sometimes the hospital and the Rape Crisis Center don't necessarily agree on patient care, or something might have gone wrong. The patient might have had a really bad experience. So when that happens, we want to make sure that it doesn't permanently damage our relationship with the hospital. So having points of contact to communicate when something does go wrong, and having that outlined in the MOU can just be really helpful to kind of define folks who will speak into conflict and engage in conflict resolution. So at the hospital, this might be the charge nurse at the time of the exam, the attending physician, or the director of the emergency department. And at the Rape Crisis Center, this might be your sexual assault advocate supervisor, your executive director, or whoever else you feel like might fit that role. And then this isn't on the slide, but I wanted to add that if you're receiving calls from the hospital or working with a lot of minors who have experienced sexual assault, it may be beneficial to have a separate MOU with your local child advocacy center or your pediatric hospital. And that can just be another community partner that you want to have a conversation with. All right, so that's a lot of information about what goes in an MOU with the hospital. So next we're gonna transition to talking a little bit more about MOUs and relationship building with law enforcement. So before we move on, does anyone have any questions or comments about the information we just went over? What if there's a disagreement? Yeah, great question. So if there's a disagreement, that's when it's really helpful to have in your MOU kind of who is going to be the point person to work through that disagreement. So let's say the situation is that the patient is non-English speaking and the hospital didn't have an interpreter that could get there very quickly. And so the patient had to wait just like an astronomical amount of time to get services because there wasn't language accessibility. And so obviously that made the patient's experience maybe a little bit more traumatizing than it had to be. So if that's the situation, then I think, you know, whoever is identified from the Rape Crisis Center and from the hospital to lean into conflict and to practice conflict resolution. And again, that could be your ED at your Rape Crisis Center or whoever supervises your sexual assault services. And then at the hospital, that might be the director of the emergency department. So those are the folks that are going to lean into the conflict between the hospital and the Rape Crisis Center. I may not be understanding. Are you asking if there is a disagreement between the hospital and the rape crisis center and it's not about a certain survivor situation. Like when you're writing the MOU, if they don't agree on terms. Okay, so I think if that happens, then it's about like meeting each other in the middle. And so, you know, your first time writing an MOU with a hospital, things may not go exactly like we want. We may not get everything that we know that survivors deserve or need. But I think by starting somewhere and maybe meeting in the middle and doing, you know, the best that we can, and then throughout over time, as we continue to review the MOU, which we'll talk about later, and continue to build that partnership and have conversations with each other outside of just that one meeting where you're writing the MOU, hopefully during that time, whatever the disagreement was over, there's more time to lean into a conversation around why that might be helpful. So my assumption is that maybe the advocate or the rape crisis center is wanting to put something in the MOU and the hospital is saying that they're unable to do that, or they don't think that that makes sense. So I think over time, just kind of trying to understand where each other are coming from, and just like you would with a survivor that you're working with, meeting them where they are and kind of leaning into that conflict and asking kind of like why this is the case rather than just being like, no, they're wrong. Because it is more like the MOU is really helpful for this accountability piece, but what we really want is for there to just be better partnerships in general and more communication. So I don't know if that was super, super helpful to answer your question, but I think it is just about relationship building and building trust. Any other questions? That was a good one. Okay, I'm going to keep going, but if there are more questions, just put them in the chat. So we're going to do another poll. Again, your answers are anonymous.
I'll go ahead and give you all another 30 seconds to answer. All right, so the question, do you already have an MOU with your law enforcement agency around forensic medical exams? 44% of you said yes, 31% said no, 0% says we do, but it's outdated, and 25% said I don't know.
Okay, awesome. Thank y'all for answering that. These poll questions just help me get a sense of kind of where folks are at with MOUs, and there's no wrong place to be. So we're all here to just kind of figure it out together. So when we talk about MOUs with law enforcement, and anyone who has an MOU with their law enforcement agency around forensic medical exams, I would love to hear from you in the chat to kind of talk about what that experience has been like. Because as I was putting together this presentation, I asked one of my colleagues to just kind of edit it for me and review it. And they made a really good point about, you know, some of the stuff that we want, law enforcement may not be ready to put in an MOU, and they have their own procedures and protocols that may not necessarily align with what we want for survivors. And so I changed this a little bit after talking with my colleague about that, to talk more about when working with law enforcement and thinking about writing MOUs, it really has to start with relationship building and building that trust, I think even more so than with the hospital, and just kind of meeting each other where we are and learning together along the way, like what each other's roles and responsibilities are. So as I go through this next section, some of this, I have like no expectation that this is going to go in an MOU with your law enforcement agency right away. I think it's going to take a long time to build up to that. But these are things when you're talking with law enforcement that it's just important to have a dialogue about and check in about. So so one of the things would, again, be anonymous reporting. So making sure that you and the local law enforcement agency are on the same page about what anonymous reporting means. NC CASA has great resources that you can share with your law enforcement agency regarding forensic compliance and anonymous reporting. And those are on our website, and I'll send out resources after this webinar, and the link to that page will be one of those resources. And so some of the things that you find on that website might influence what goes in your MOU. Some of the pertinent information that I think is pretty relevant in initial stages of MOUs is where is the evidence going to be stored. So if the patient decides that they do want to do an anonymous report, then where is that going to live? It should be stored at law enforcement support services or less. However, if that's not supported in your community or not reflective of what's going on in your community, that should be in your MOU. We also talked about during the Survivors' Rights webinar about the difference between blind reporting and anonymous reporting. So I'm going to do a brief recap of that. Anonymous reporting, all of the survivors' information is confidential, and the only thing that law enforcement is responsible for is picking up that anonymous kit and taking it to the storage facility. They don't really interact. They shouldn't really interact with the patient. They shouldn't know the patient's name, things like that. With blind reporting, the survivor may choose to have a conversation with law enforcement and give some details of what happened during the assault, but they still don't necessarily have to give their name or other personal information that they don't want to give. Anonymous reporting can be done only if the survivor chooses to get an exam at the hospital, but with blind reporting, that can happen regardless of whether or not a forensic exam is done. And then all survivors in the state of North Carolina have the right to report their assault anonymously, but not all law enforcement agencies have blind reporting protocols. So, and there are benefits to blind reporting, which you can find in the Survivors' Rights webinar. And so you may just want to check with your local law enforcement agency about their blind reporting protocols. And if they don't have any, it could just be an opportunity to kind of start a conversation about that, talk about the benefits, and then, you know, maybe down the road that goes in an MOU. So another thing, and this kind of came up at our member meeting, is wanting to make sure that we have trauma-informed interviewing, and what does that look like? And when we say trauma-informed interviewing to a law enforcement officer, do they think that means the same thing that we think that means? And so having a conversation about that and working together to get on the same page, I think can just be really helpful and can be part of that relationship and rapport building. But some things that may come up when you're talking about interviewing would be that best practices have found that giving the survivor at least 2 full sleep cycles before doing an in-depth police interview is helpful in mitigating re-traumatization and memory recall. So you may want to advocate for that, and that may mean that you do some neurobiology of trauma education, and kind of talk about the reasons why that's the case and why it can be helpful and even benefit the investigation. And it's also, you know, when talking about this, you can also talk about how doing an interview at the hospital or asking a lot of questions the day of or the day immediately after the assault without giving the survivor time to rest and process can just be really hard. And, you know, the patient survivors are tired and they need that time. So another thing is if the survivor is requesting for the advocate to be present during any police interviews, language around this can help in the MOU for the police not to conduct any interviews without the advocate present, and this can help ensure the survivor's right to have an advocate. That also we talked about that at our member meeting in the session about follow-up with survivors. Real Crisis, Tracy Kennedy, she talked about this. So if you want to talk or learn more about, you know, how to make sure that you do have an advocate present during an interview, it may be helpful to go back and watch that session from our member meeting. So another thing when talking with your law enforcement agency about MOUs and relationship building is, again, confidentiality. Sometimes law enforcement doesn't know what advocates' confidentiality limitations are. So it can just be helpful to have that language in your MOU that without survivor consent, the advocate can't release information, and advocates can't discuss the case with the investigating officer without that release of information signed by the survivor. So just kind of putting that out there, I think, can just be really helpful and maybe reduce confusion and frustration. Is there anything else in your experience that you can think of that would be helpful to include in an MOU with law enforcement? So someone said, our agency cross-trained our sheriff's department last week with the inclusion of brain neurobiology, trauma in the brain, survival reflexes, victim services partnerships, and hospital accompaniment. That's great. And was that well received? Good. Yeah, they said that that was well received. So yeah, I think, you know, it's a good place to start. And you know your relationship with your law enforcement agency best, and you kind of know what's been going on and what are the issues in your community, what's the miscommunication. So, you know, starting there. So some of this stuff that we're talking about today, maybe like your law enforcement agency and you aren't on that level yet to have this conversation. And if that's the case, what level are you on, and where can we start? Where is a good starting place? I think is the best thing to kind of think about. Okay, great. What about victims in court not wanting to face the defendant in court if the survivor does press charges? So I am going to be honest, I don't know all the details of that. I was never a super strong court advocate. That wasn't what I did a lot of at the Rape Crisis Center that I was at. So what I can do is I can look up that information and I can send resources out as a follow-up with this webinar. But I think, you know, it depends on the situation. I do know that there are so like if it's a criminal case, the DA or the prosecutor, whoever is representing the survivor, they may be able to advocate for the survivor to only have to be there on the day that they give their testimony, if that's something that's going to happen, and the other days not having to be there because they're not the one, you know, that's testifying, and because we do want to reduce trauma. So I think that this also kind of speaks to the relationship that we might want to have with our district attorney's offices, which we're not going to talk about today. But I think that that's, you know, another conversation, another community partner that we want to talk about is, you know, how can we mitigate re-traumatization for survivors in the courtroom? And if there's anything else, just feel free to put that in the chat as I keep going. All right, so the next thing that we're going to talk about is when survivors are being sent out of county. So as the Rural Sexual Assault Services Specialist, and with North Carolina being mostly rural, we don't have a lot of large hospital systems. And so I hear from a lot of rural advocates that the survivors that are going to their local emergency rooms or local hospitals end up being sent out of county to like the nearest large metropolitan hospital system. So I have another poll to get a better understanding of some of the reasons I have heard most often and whether that's happening. Again, it's anonymous, so I'm not going to know which county this is happening in, but you're always more than welcome to email me or let us know in the chat if this is happening in your county. But if patients are being sent out of county for medical care, what is the most common reason? And if the reason that you hear the most isn't listed here, then you can type that in the chat.
Great, I'll give everybody another 30 seconds to answer. All right, so 9% of you said no ER in our county. 36% said hospitals say they have no stay nurses. 9% said hospital refuses patient for other reason, and 55% said this does not happen in my county.
Okay, well, I'm really happy to hear that. It sounds like for the majority of you, that's not happening, so that's great. For the ones that this is happening, someone said that there's no pediatric stains and that there's training in process. So I think that's also an issue that we have to think about. And if you don't have a CAC, Child Advocacy Center, in your community or that serves your service area, you may have more trouble with this. So again, if you do have a CAC in your area and you haven't talked with them about, you know, a partnership if you are seeing minors, because if I'm not mistaken, a pediatric SANE can do the exam for anyone under 18, or perhaps it might actually just be 16 and under. I'll double check on that. But so, you know, if you're seeing teenagers, they still might prefer or want to be seen by a pediatric SANE, and so if there's none available in your area, that may cause complications. But as far as other issues related to the hospital saying that they don't have any SANEs available, if it's for an adult, any physician can do the forensic and medical exam. It is preferred for it to be a SANE because they do have the special training. But any nurse at a hospital can do the forensic medical exam, and the pelvic exam will have to be done by a physician. So that may be something that your hospital isn't aware of. I've talked to a lot of hospitals and we've had this conversation and they've said, oh, I didn't know that. I didn't realize that. So it may start with that little bit of education of, any nurse can do this. And then as far as, not having an emergency room in your county, I know that happens in a lot of our rural counties. So if the survivors you're working with are consistently being sent to the same out of county hospital, it's probably a good idea to work on an MOU with that facility. So reaching out, so you'll probably have to take the lead on this, but reaching out to that out of county hospital and saying, hey, we're in this nearby county. We know that our survivors are being sent there a lot. Can we talk about a potential partnership or some communication or what we can do to kind of make sure that we know when this is happening so that we can be there for them. It also might be helpful to have an MOU with the Rape Crisis Center in that county, because if the survivor doesn't reach out to you first and they're from your county and they're sent out of county, then there might be some confusion with during and post medical exam advocacy. So the hospital probably won't call you if you don't have that relationship. And so they're probably going to call whatever Rape Crisis Center serves their county. And then that Rape Crisis Center may send an advocate. And you may be unaware that this survivor from your county has these needs. And so if we can just kind of be aware of that, then hopefully we can mitigate how much traveling out of county the survivor has to do, or transportation issues related to getting the survivor back and forth between counties, and things like that. And we want to make sure that the survivor kind of knows what the follow-up plan is. So if it's going to be, and it's up to them, if it's a small county, the survivor may choose to do follow-up services in the larger county for confidentiality reasons, or wanting it to remain more anonymous, and that's okay, and we can support that. But if they don't know that they have the option to see someone in their own county, but that would be easier for them, we would just want to make sure that they know that it's available and that they have a plan. And I know that there's a lot of advocates that I've talked to who will drive to the next county. But again, that only works if you know the survivor's there. So just making sure the hospital knows that if this is happening, to call you. So some of the information that would go in an MOU with someone out of county is when someone will be contacted from the Rape Crisis Center, sharing resources and information. So you may want to put like brochures and follow-up information at that out-of-county hospital for them to give out, transportation for the survivor leaving the hospital if they don't have their own, what law enforcement agency is going to be contacted, and where the forensic evidence will be if applicable. So are there any other issues that y'all are seeing with survivors being sent out of county that you have any questions about or feel like I didn't mention today? Okay, I'll move on, but if something pops up, we can go back to it. All right, so the next thing we're going to talk about are culturally competent MOUs. So we're always looking for ways to incorporate education about serving survivors from marginalized communities, and the MOU is a great place to implement some of these practices. So one thing that is helpful is when you're writing your MOU, it can be helpful to use language that's easily understood by anyone and not only the people in the field. And then also advocates use language that law enforcement hospitals don't use and vice versa. And so making sure that we're using language that everyone can understand just makes the MOU feel more accessible, and I think can help people feel like they're all kind of actually working on it together. So I would start there. And then also making sure when you're writing your MOU that you're using gender neutral language when referring to harm doers and or patients and clients. So not exclusively using she as the patient and he is the harm doer, and using they or general terms like patient, client as often as possible. It's also important to include language around trans survivors. So an example of what this might look like in your MOU is if a trans survivor presents to the hospital for a medical exam, the hospital agrees to treat the patient according to their identified gender, regardless if it matches their physical sex. In your MOU, it's also kind of one of the examples I gave earlier is around language access. So we want to make sure that there's information in there about what's the protocol, what's going to happen if someone presents to the hospital and they don't speak English. So NC CASA does offer our language line, and I'll make sure to put that in our follow-up resources. And then I also have a resource for language access cards that can just be helpful for you to have on you as an advocate going to the hospital or to leave at your hospital. But we want to make sure that the hospital agrees to accommodate for non-English speaking patients. And we want to make sure that happens in a timely manner. So the forensic medical exam already takes a really long time, and sometimes there's a wait before the survivor can be seen. And then if we also have to wait for a translator, that's going to be like a really, really long, re-traumatizing potentially, and just like exhausting process. And so the sooner that we can get the ball rolling on getting a translator and identifying translators that are available, the better, I think, for everybody, but especially for the survivor. And so if your rape crisis center has a bilingual advocate, it may be worth putting that in the MOU, or at least communicating to the hospital that you have a bilingual advocate and what language they speak, so that, you know, there's kind of an awareness of whether or not this bilingual advocate can be there to help, or if a translator is going to need to be called. And also just for whoever takes the call from the Rape Crisis Center, making sure they ask the hospital or whoever's calling, asking for an advocate to come be with the survivor, asking what is their primary language, because we shouldn't just assume that it is English. And if we get there and we find out it's not English, then again, that just like adds to the process. And even if the survivor does speak English, but their primary language is something different, it is more beneficial, and there is research to show that being able to process trauma in one's primary language or native language helps in the healing process. So if the survivor speaks English, but they would rather have an advocate that speaks Spanish or Arabic or any other language, then we should do our best to accommodate that. Another example of how to incorporate trauma-informed practices and cultural competence would be to include in your MOU information or language around the hospital doing its best to accommodate the requests of patients who wish to have a nurse or practitioner that's from the same racial or ethnic group. So I think we talked about this before in one of our medical advocacy webinars, but there are a lot of reasons that patients from varying ethnic or racial groups may not feel comfortable with a nurse or a practitioner of a different ethnic group. There's a lot of historical trauma related to the institution of healthcare and medicine. And so, for example, if someone from the Native community comes into the hospital, they may not want a nurse or a practitioner who reminds them of the person who assaulted them or reminds them of some of their historical trauma. And so being able to accommodate that as best we can, I think, is really important. And again, just minimizing re-traumatization and making the survivor as comfortable as possible. This may not always be possible, and sometimes we may have to have that conversation with survivors, but we should do the best we can and respect the survivor's choice. Another thing to think about is for patients with existing mental health issues, especially if they have severe mental health issues such as dissociative identity disorder or schizophrenia, or another severe mental health concern, they may have an ACT team or a community mental health team that they work with. And so it can be helpful to ask the patient if they have a community support person that you want to call. And that can just be helpful as it's someone who's familiar to the patient, who knows the patient's history, who kind of knows, if the patient is getting upset, maybe specific tools that work to help them feel more comforted. So being able to reach out to these professionals with the patient consent might just be really helpful and can mitigate, again, some of the trauma that may be caused if the hospital or the advocate isn't really sure how to work with someone with that sort of mental health issue. And it's okay if you're not, that's not typically part of our everyday work. And so we want to make sure that patients with severe mental health concerns are treated with the same dignity and respect. And then lastly, although I'm sure there's plenty of other things that I'm missing, is ensuring that the language you use in your MOU with your hospital and your law enforcement agency is not only for patients and clients that have documented citizenship, and in having conversations around, if a patient is undocumented, making sure that we're supporting that patient and not also making them feel like they did something wrong or criminalizing them or anything like that. So the next thing that we're going to do is we're going to take a look at a sample MOU. So before we move on, does anyone have any questions or examples or things that I missed when it comes to culturally competent MOUs? Okay, I'm going to keep going, but if you think of anything, we can go back to it. All right, so now we're going to take a look at a general sample MOU. It is not comprehensive. It doesn't include a lot of the information we talked about today because y'all are, again, the experts of your community and should work together with your community partners to craft your MOU. But these are just some general things that may be helpful. Can everyone see that okay? Okay. Ignore the 1,000 tabs that I have open. I'm really bad about that. So this MOU is a sample that's really specific to your rape crisis center and your medical center. So this does not have anything to do with law enforcement. I don't have a sample for law enforcement. And so if you're working on crafting an MOU with law enforcement and you want some support or want me to review it, just let me know. And my email is at the end. So some of the things that are listed for rape crisis agency roles and responsibility: providing advocacy services 24/7 to patients presenting to the medical center.
Hey Leah, this is Gabriella. I don't know if it's just me, but I can't see your screen. I'm still on the general sample MOU PowerPoint slide.
I think I know what I did. Let's see. Can you see it now?
Yep, you're good, thanks.
Okay, sorry. The Rape Crisis Center roles and responsibilities: provide advocacy services 24/7 to patients presenting to the medical center, accompanying patients through triage, examinations, and reporting if they choose, and providing emotional support throughout the process. Advocate will arrive at the medical center as soon as possible. Obtain verbal or written consent from the patient that the patient would like the advocate to be present. Will provide patient with information on follow-up resources, reporting options, support options, and other follow-up services as needed. And then this is an optional one, but can be helpful depending on your relationship. Provide ongoing education and support to the medical center personnel in regards to serving patients who have experienced sexual assault. RCC will provide medical center with pamphlets, brochures, or other informational materials about your services. And again, you may want to add things, take things away, whatever works for you. And then the medical center roles and responsibilities. So contact the RCC as soon as possible. Protect patient confidentiality by not sharing with the RCC identifying patient information. Provide patient with information on the Rape Crisis Center, medical accompaniment services, and inform them that once the advocate arrives, it's okay to ask them to leave. The medical center will do their best to provide patient with a private waiting room. If patient chooses not to have an advocate present, the medical center will provide patient with your informational materials and other follow-up resources. After the advocate has arrived, personnel will ask client for consent to share any information the patient has already provided. Medical center will allow reasonable time for the advocate to arrive before beginning an examination. Will allow advocate and patient to meet privately if desired. Will not charge patient for the exam. It will be billed to RVAP. Will not call law enforcement to come take a report without patient requesting law enforcement be present. Again, that there may be a reason why this doesn't go in your MOU with the hospital, and that's a conversation with your hospital and your law enforcement agency. Medical center will respect patient's right to refuse any part of the kit. A general understanding of anonymous reporting and be able to present this as an option for a patient. And then this line below is talking about open communication about differences in care, you know, kind of who's going to talk to who in the event that something goes wrong or there's a complaint that's brought up, and then a space for both to sign. And there may be more people who end up signing. And again, there may be things that we talked about today that you want to add to your MOU, and there may be things in here that aren't relevant. I will send out a copy of this with the resources so that y'all can look at it and have it as an example. And again, I'm always happy to review any MOU that you put together. Are there any questions just from looking at this right now? Another thing I'll add is that we want to make sure that MOUs are detailed enough to hold each other accountable, but broad enough to encompass the scope of services that all parties are providing. Okay, I'm going to stop sharing this screen and move on, but if there are any questions, just let me know or you can email me after. Okay, can everyone see that? Okay. So the last thing that we're going to talk, or two more things that we're going to talk about, maintaining MOUs. So it's not uncommon, like we kind of saw when we first did our poll, for programs to have created an MOU with their hospital or law enforcement in the past, but it hasn't been maintained and it's no longer up to date. Sometimes people don't even know that it exists. That's not uncommon. There's no hard and fast rule about how long an MOU should last, but an annual review is a good place to start to make sure the MOU is still working and up to date. In order to prevent this lapse from happening, you should agree, you and the party that you're entering in the MOU with should come to some terms for review and how to strengthen the relationship. So some things you may include are annual MOU reviews and meetings to talk about the limitations, strengths, and changes you want to see. Every so often, and especially during the initial stages of creating the MOU, invite the other party to come to your rape crisis center to see what your program is like and ask them if you can have a tour of their space as well. You know, that might be a tour of the emergency department or the space in which the exam is going to take place. And then making sure, again, that there's clear points of contact that are willing to communicate with one another if any issues arise. It can be really hard after a lot of negative experiences, but I think always going into a tough conversation with the mindset that the other party didn't want to cause harm is more productive than assuming the worst and going into a situation ready for conflict. Start by being curious about what happened and use your advocacy and counseling skills to provide education about how things can be done better the next time. And we talked a lot about this when we spoke about law enforcement, but an MOU is an important part in relationship building. It might just be the first step, but for stronger relationships, we need more than an MOU. You know, we need to talk to each other more than once a year when we're updating this. We want to make sure that we're in communication. So the last thing we're going to talk about is MOUs during COVID-19. At our member meeting, I heard programs request support when it comes to best practices for hospital response during and post-COVID. We don't have time to cover that today, but we will work on addressing this in a different platform. What I will ask is that for those of you who have had MOUs with your hospital, how has that changed during the pandemic? Someone said, we did not have to do revisions. Our hospital accompaniment has continued as normal. Okay. Someone said, we are moving to a virtual platform that is already in place at the hospital and continuing to offer phone advocacy. Okay, so for the virtual platform, would that be like a Zoom or FaceTime situation? similar to that, but different platform video. Okay. Do you mind if you have any resources on this? I would love for you to send them so that we might be able to share them with other folks who might be wanting to do that, but haven't really known where to start. So if you have any resources, that would be awesome. I think the thing that we have to recognize, thanks, Elizabeth. I think the thing that we have to recognize is that this is a grounding moment, that there are things that are out of our control and that we must remain flexible, and that our duty is always to support the survivor, and we are advocates and we are resilient and we are creative. And so in times of crisis like this, you know, as people have shown, you know, we're still advocates. We know that sexual violence is still occurring. We know that people are still needing our support. And so some of the protocols that we had in place may not have been sustainable, but we're able to keep doing what we need to do. If you already have an MOU or you're thinking of writing one for this first time, I think this also kind of taught us that it's important to talk about crisis planning. So that may mean preparing for the next time that there's a crisis or a public health crisis, pandemic, that, you know, what's our plan? What do we have in place? And so right now, as folks have kind of started talking about virtual platforms and phone advocacy, is that something that we're going to continue? Is that something that goes in our MOUs now? You know, just kind of learning from this experience, I think is what we've all had to do. So that's all I have on MOUs. I know that was a lot of information. Again, I'll send out some resources afterwards, and this was recorded and will be available on our YouTube page. But are there any lingering questions or comments that you all have?